But basing a disease model that then becomes the standard for the field on interviews with AA members is not science. But nonetheless, the message that went out was, and this was the story I learned, addiction is a permanent, chronic, progressive disease only arrested by complete and total abstinence. And if you don't accept that and accept your powerlessness, you're in denial. And eventually, you will be dead, incarcerated, or in the insane asylum. And if we helpers don't support or enforce abstinence, then we're enablers. So that gave rise to this abstinence-only edict, that's the first priority, right? So the pressure is to accept your disease, accept this narrative, or else. So it's really about fear, it's about disempowerment. And also, I think it risks explaining something that it's just naming.
Okay, welcome to the show. I'm joined here with Professor Marc Lewis and Dr. Andrew Tatarsky. In my opinion, these two guys are probably two of the leading pioneers in transforming the paradigm in addiction treatment. So I thought it'd be really interesting to bring them together for a discussion here today. So to get started, let's maybe just I wanted to ask how familiar are you with each other's work, and what do you know about each other's work? So maybe Andrew, if you could kick us off here, and then we'll go to Marc afterwards.
Well, I'm quite familiar with Marc's work. I haven't read his first book, but his second book is kind of my go-to book to really help us think very deeply about, the title of his book, why addiction is not a disease. And on multiple levels, he discusses that beautifully, and it very much overlaps with my work, which I think I add a little something, or we use slightly different language, but I think our work is tremendously consistent. And so, Marc has been my really go-to neuroscientist, to sort of continue to inform me and educate me about the, brain basis for addiction, or what we call addiction. And this is maybe another thing we can even kind of play with. What is addiction? And so on. But and I had the pleasure of presenting with him at a conference several years ago on the paradigm shift in addiction, and so we got to kind of tag team it a bit, and that was when I had the pleasure of meeting Marc in person for the first time.
Yeah, I remember in New York. That was great. It was a really nice day.
So yeah, Marc, same question. What do you know about harm reduction, and and thoughts on Andrew's work, if you've come across it before this conversation?
Truthfully, not a whole lot. I mean, I'm familiar with his thoughts, motives, orientation, because we did share that conversation. I read one of the things that you sent me. We're so much on the same page. It's like, and I haven't plunged in. And frankly, I've not read very much about addiction lately. I'm thinking about addiction in relation to broader, psychotherapeutic contexts, and the suffering that people go through, and depression and anxiety and PTSD and everything else, one of which has various outcomes, one of which can be addiction, and many others as well. So I think of things more broadly these days. I'm not reading about addiction. I'm not writing about addiction. I'm really invested in thinking about parts a la IFS, internal family systems. I'm finding it a very intriguing way to do things, and trying to map people's roots as they go through very painful emotions and frustrations and hit walls, and then branch off into places where they can feel a little bit more comfortable and a little bit more in control. And I see addiction as one of those places. And I never questioned the idea that people need to do what they need to do. And if it hurts too much, and if it's harming them too much, they need help. Okay, fine. But we don't need to tell them what to do. We don't need prohibition and rules and constraints, and we certainly don't need punishment and humiliation in our treatment of addiction. So Andrew and I just kind of assumed we were on the same page on all that.
Very cool. Right. So I think whenever we're having these discussions, it's always a good idea to sort of make sure we're on the same page with what we're talking about and to clarify our terms. So can we maybe talk here maybe about what your definition of addiction and what your understanding of addiction actually is? And we can go back to Andrew here and then back over to Mark.
So I think of what we call addiction as an experience or a set of experiences. And actually, I've spoken to quite a few experts or leading people in the field who come from different perspectives. And there seems to be, I think, a fairly general agreement that there is a set of experiences that we call addiction, a compulsion, craving, the experience of losing control, or quote, inability to stop despite negative consequences. And I think, traditionally, those have experiences and associated behaviors have been evidence of the so-called disease. But I like to emphasize that these are experiences, and reducing them to a simple biological explanation is super problematic in many, many ways. And, Mark writes and talks, very eloquently about that. But so I actually understand that experience of addiction as being multiply determined by an interplay of, psyche, bio, and social factors that someone named, a psychobiosocial framework. And so there's this dynamic interplay between what's going on inside of us, our bodies, our minds, our emotions, our parts, and what's going on outside of us. And when our experience of suffering or pain or distress becomes overwhelming, there's a tendency to turn to something to try to comfort oneself, to adapt, to care for oneself, in spite of the fact that that may have negative consequences or risks associated with it. But so I think of it as a meaningful relationship to substances or activities, a multiply meaningful relationship. And so that shift really enables us, or it opens up so many different possibilities for supporting people and making positive change. It also challenges the shame and the stigma that the disease concept was supposed to, help fix, because it's really, it enables us to have empathy and compassion and respect for people's struggles and their choices to turn to things that may, in the long run, not be the best solutions, but maybe the best solutions until better solutions are found or created.
100%.
Yeah.
100%. Mark, let's go over to you here now.
Well, I agree with everything. Like I said, I think we're on the same page. It's pretty clear. I don't think about the brain very much these days. I'm really only interested in the brain in very specific ways. For example, in the kind of therapy that I do using internal family systems ideas, we have parts of us that use judgment and self-shaming and self-denigration, which are kind of online and keep coming, and the feelings of shame and anxiety and inadequacy kind of sit there and hurt more and hurt more. And then there's an impulsive part that takes off and says, I know how to fix this. I need a drink. I need some pills. I need to do something here. Okay. And sometimes you do. And sometimes you do. And then if it hurts more, you try to figure out another way. So what we do, the kind of therapy that I use, is we try to talk to those parts. And the part that reaches for the substance or activity, sometimes very impulsively, well, it might be useful to think about the brain there, because the brain does some things very quickly, right? The amygdala is registering pain and solutions and challenges within roughly a fifth of a second, whereas the prefrontal cortex is thinking, well, what am I going to do about this? This isn't working very well. Can we talk about this? Let's think about other possibilities. Takes much longer, takes a few seconds before you even can identify what it is that you're trying to figure out. So, then maybe it's useful to think about the brain as supporting very different kinds of cognitive emotional processes that feed into addiction and that can help resolve addiction. But in therapy and in trying to help people, it's really about trying to connect with the different parts of oneself, the parts that are needy, scared, critical, shamed, and hurting, and to try to feel more at peace and help them feel more at peace so that you're all talking to each other. And that allows you to slow down and find other solutions. And as Andrew says, it might not be today, or it might not be this week or this month, it might be next year. Sometimes it takes a while to figure out how else to contend with this kind of emotional pain.
So interesting, Mark. And so in the IFS model, just to sort of, I suppose, summarize here a wee bit, like we're sort of saying that there are addicted parts and these are quite maybe immature and impulsive. And in the IFS model, you're essentially trying to almost disidentify or disentangle from these parts and step into what you guys call the self, which is more maybe the prefrontal cortex where it's wiser, and this separation enables you to make wiser decisions and maybe not be as impulsive.
Not exactly. Yes and no. I mean, the impulsive addict self, which of course has been a familiar notion from AA for years, forever. We generally, in the addiction treatment world, you try to get rid of it or say, be quiet or stop doing that or leave me alone. That's not working. So just get off, get out of my house. That doesn't seem to work very well, very often. So what we do with self, the notion of a caring feeling that wants to connect all the way around to the different parts, the child parts, the shame parts, the judgmental parts, but also the, I want to get high. I need to get high. I really need to get high. And instead of trying to get rid of that part, you try to accept and connect with and really actually empathize. Yes, yes, that really does feel better, doesn't it? It really does feel helpful. Yes, I'm glad you finally, recognize that. I'm not just your enemy. No, I'm trying to make you feel better. Yeah, okay. And then once that connection starts to relax and, settle down, then you can start to think about other ways to deal with or to delay emotional regulation that don't have such a cost, that don't make you feel so crappy the next day or the day after or the week after, or wreck your marriage or your life or whatever, or your job. You can still do that without getting rid of that impulsive part. You just have to be able to settle it down enough so that you can still think.
Can I add something to that? I was introduced to parts work before IFS through psychoanalysis and a kind of wonderful work called Voice Dialogue, which Hal Stone and Sidra Wickelman created back in the 80s. And what they talked about was precisely this, but in different language, that, we humans are really a collection of sub-personalities, sub-energies, parts, and that sort of the goal of personal growth really is to kind of acknowledge, recognize, and integrate all of the parts. And one of the things that they taught me, which I find to be so fascinating, is that we don't have to like all of our parts equally. But if we don't accept them, if we disown them, if we dissociate them, if we deny them, they can come back in what they called a demonic form. So think trauma dissociation, right? Anger wasn't permitted in my family. Grief wasn't permitted. I got hit when I cried. Sexuality wasn't permitted for whatever reason because of my sexual abuse. So I had to disown it. But those energies, those parts live somewhere. And I've thought that they live in this kind of dissociated netherworld within the addictive experience. Uh, so they find expression in this kind of split off way. Right. So from that point of view, the work is along the lines of what Mark was saying, to create a space for people to kind of explore, rediscover, reconnect with those parts and invite them to speak, and work on integrating them into one's experience of self and in one's relationships. And so we might think about that process as, a core, central part of healing the addiction, because the energy, the juice, the parts that are driving it are now welcomed and a part of our, more integrated experience. And they're not necessarily immature parts. I mean, I think that I wouldn't want to judge them that way. They might be, like in one of my patients' experiences, she actually was, when we began to do this work of supporting her in exploring and rediscovering what part was living in that experience, this feisty, energetic, courageous, creative part came out that had been a part of her experience as a young person, but was really traumatized into, the darkness in a way, and was living in this kind of addictive relationship to opioids, and rebelling in a way against the parts or the social context that was saying don't use drugs. When she could kind of identify, liberate, and kind of integrate that part, we actually started talking about how she could be more herself, more fully present, more assertive and creative in her life.
Yeah, as you say, our addictions are meaningful. They're full of meaning. And it's a complex, rich part of who we are. Really recognizing that we're in pain and we're kind of helpless and we don't know what to do about it. And the impulsive part. And now, yet indeed, we do want to unblend enough so that the impulse doesn't just drive us straight into the activity. So you do want to unblend, which is what they call an IFS, enough. Impulse is I should say compulsion, really, not impulse, but more compulsiveness. It builds up like a wave very quickly, and it's mediated by the striatum, which is an older part of the brain that doesn't really think. It's just ready to act, to do. So yeah, we need to unblend enough to be able to give ourselves some time to consider the options, the positive. And that moment of choice, or those minutes or seconds of choice, are so important in changing the way we deal with emotional pain. But the unblending is one thing, but you can't just, shut it out. And we do tend to do that. I had an opioid addiction, a really serious one, throughout my 20s. And it was so bad, and I felt so terrible about it, and I was so ashamed of it that I just kept doing it, because I just felt like a complete loser, and I didn't know what else to do about being a complete loser other than to try to recreate this world in which I felt more safe.
I think one of the things that's most interesting to me about the harm reduction approach, Andrew, is that the addiction is often the central source of meaning in somebody's life. So if you've got an abstinence only model, this is a major ask for you to say, I'm not going to treat you unless you give up this addiction. To me, that seems like unfair, So can you maybe tell us about this and why this is such an issue?
Well, not only have I thought it's unfair, I thought that it could be experienced by the person as an attempt to kill them. I mean, to the extent that the substance for many people helps people stay alive, helps people manage, what would otherwise be overwhelming feeling states. So that to say, you've got to give that up first, before we can talk.
It's crazy.
Crazy. It's crazy. It's like, no wonder the entire traditional addiction treatment is an abysmal failure and fails to treat the overwhelming number of people that struggle. So it is based on this incorrect understanding of addiction, that it somehow is this separate process, that needs to be arrested. And that's an interesting idea, right? Arrest the disease before we can do anything else. And not only does that contaminate the addiction treatment field, it's infected the entire mental health field, the abstinence-only ideology, so that many otherwise good therapists think, well, they have to get sober first. That's why, less than 1% of people that struggle actually go to traditional addiction treatment. And
Is that still a thing, Andrew? Do
less than
people,
half of them complete it.
does that ideology still have a solid place in addiction treatment? The idea that you have to stop before you get help? Like I can't believe that's still a thing.
I think that it is still, it had become so institutionalized throughout our societies that, programs still have, this idea in their bylaws or their guidelines, their treatment manuals, right? But I think it's more insidious than that as well, because I think that narrative, that addiction recovery story, has been so ubiquitous throughout our culture that it lives within all of us consciously and unconsciously. And so even while many otherwise good clinicians are like, that doesn't make any sense to me, but that's what we were taught. That's what we have to do. I think it's changing as, what we have to give it a name. We call it harm reduction, means for me, don't hurt your patient before you start working with them, or don't make presumptions about what they need and how you can be helpful. Before you've established a therapeutic alliance and relationship with them. But so it's changing, but I think it still is probably the dominant approach to treatment.
Mm-hmm. I'm sad to hear it.
So for example, 6 months ago or 7 months ago now, I began working at this new institution, which brought me on board to actually create a whole harm reduction informed continuum of care, outpatient, inpatient, and we're doing it. And it's very, very exciting. So we're seeing patients who are coming in actively using alcohol or other substances, and we're welcoming them and seeing if we can engage them in a meaningful way, and then work with them to sort of figure out, what are your goals? What approach to change is going to best serve you? We've got all of these different modalities. Our wonderful admissions coordinator is so excited because she said, before I came on board, these patients would have been denied treatment. They might have been denied it with compassion and love. Hey, you need to go to a detox first before we can treat you. But if the patient says, I'm not going to detox, I'm not ready to go to rehab, they were denied care. And this is has been one of the more forward-thinking places, So now we engage them wherever they're ready to get started. Let me tell you just very quickly a little story. We had a man who was drunk on the informational phone call. He was drunk during his intake. He was drunk when he came into his first therapy sessions. And in fact, his therapist was quite uncomfortable, and I had to really, give her a lot of supervision to hang in there and to see, why was he coming even though he was drinking? What did he want? And he really wanted to stop, and he thought he could on an outpatient basis. And within a month and a half, he realized he couldn't stop drinking in that out of control way. And he thought and agreed to go into a detox and a rehab. And he became a star patient. And now he's back with us. And for the moment, he's not drinking and doing incredibly well. In other cases, we see people coming in a similar way, and we can start to engage them to begin stepping down the substance use. in a positive direction. And that's how it usually goes. And people come in who are committed to abstinence, and we're like, hey, we'll welcome, you and support you in that goal as well. That's what I think of as a kind of a full spectrum harm reduction informed continuum of care, where we can actually invite everyone in wherever they're ready to begin their process.
And the logic behind that, which to me seems so, necessary and so exquisite. And so we almost don't even have to talk about it because it's in a way so obvious, even though it seems to get overturned by by institutional habits and ways of thinking, is for people to have choices. This is one way to feel better. There are other ways to feel better. There's a lot of ways to feel better. Talking can feel better. Having a cigarette can feel better than having a drink. Having 1 or 2 drinks can feel better than having 8 drinks. Not drinking from Tuesday to Thursday might feel a lot better on Friday and Saturday. There's a lot of ways to integrate using with the general goal of changing one's habits and changing the way one lives and the way one connects with substances. It's not one or the other. Choice is a wonderful thing. Well, yeah, now, yes, the prefrontal cortex, that's where we do our choosing. That's where we do error monitoring and error detection and perspective taking and all that good stuff. We need a chance to just start to use it, and then we have a field of possible choices. There's a person in the IFS hierarchy named Cease Sykes, Sykes. Andrew, I don't know if you've run across her. She's terrific. She's got a book that just came out. Now, I know that you interviewed her, and I know that she is speaking or will be speaking in a fall lecture series. IFS on addiction. I think the book is called Internal Family Systems for Addiction or for Addictive Processes. But she's really quite brilliant. And it's really all about being able to choose. Once you have that, the rest is available.
So there's choice, there's options, and all of that, I think, hinges on agency, which I know, Mark, is also something you've written a lot about. The disease model disempowers and takes away people's sense of agency, controlled by this disease. Right. And the harm reduction tilt sort of wants to put the person back in the driver's seat. Okay, it's about your choice, your needs, your goals. How can I serve and support you? And actually support your agency with skills, with strategy, with support, etc. And that shift is often dramatic in people beginning to march in a positive direction in relation to their problematic behaviors, step by step. I see that, we don't need to know where we're going to wind up, to begin the journey. Let's just start working in a positive direction, kind of exploring, experimenting, cutting back, and kind of discover ultimately what your ideal, healthiest relationship to substances is.
We've mentioned it a couple of times in this interview, but I think it'd be important to clarify, the disease model. Andrew, I've heard I've read you've written that it actually does more harm than the drugs themselves, or it can do more harm than the drugs themselves. So that's quite a big statement. So maybe if we could just expand on what actually is the disease model and why is this so harmful for people suffering from addiction?
Well, the disease model, as I learned it back in the early 80s, which was kind of Jelinek's version of the disease model. Jelinek wrote the disease model of alcoholism in the middle part of the 20th century. And it was based on interviews with AA members. So, AA is a wonderful program for many people. It's not a treatment. It's not a scientific-based program. It was a bunch of people who got together and, figured out what was helpful to them at that time. Most people don't resonate with the program. Many people do. But basing a disease model that then becomes the standard for the field on interviews with AA members is not science. But nonetheless, the message that went out was, and this was the story I learned, Addiction is a permanent, chronic, progressive disease only arrested by complete and total abstinence. And if you don't accept that and accept your powerlessness, you're in denial. And eventually, you will be dead, incarcerated, or in the insane asylum. And if we helpers don't support or enforce abstinence, then we're enablers. So that gave rise to this abstinence only edict, that's the first priority, right? And so the pressure is to accept your disease, accept this narrative, or else. So it's really about fear, it's about disempowerment, and also I think it risks explaining something that it's just naming, it's just describing. So it can support a lack of, or support and a lack of, or an inability to be curious about what we've been talking about, the meaning, the multiple meanings. So it actually can reinforce dissociation, which then perpetuates the so-called disease because the issues that are driving it are kept out of awareness. And I actually think that that is what has characterized the whole addiction treatment field, and it gives rise to being punitive. Or, if I haven't resolved my trauma, and the way I got sober was by, stuffing it underground with the disease model, then anybody else who's talking about, using in a safer way is going to be a threat to me, and I'm going to have to attack them, right? So it kind of is unresolved trauma that then you have to identify with as the aggressor and then keep perpetuating that trauma on others. And then we have a criminal justice system that does that too. It's bizarre. What are your thoughts about that, Mark?
Yeah, everything you said, I agree with. Also, the disease model, in a way, it came along in the, I guess, the 50s, 60s, and so forth. And then it became the brain disease model in the decade of the brain in the 90s. But the other problem is that we're going to help reduce your stigma, your shame, by announcing that it's not your fault. It's not your choice because you have a disease. And I love my talks showing a photo of a billboard in Massachusetts where you have 5 people looking semi-okay, but not particularly happy. And the slogan is, "It's not a choice, it's a disease." And they're looking like, thank you for taking the blame away. It doesn't take the blame away. Being told that, you're going to feel better because you have a mental illness doesn't work very well. It's like, if it's a disease and if it's here, it's a mental illness. And if that's the dominant force in your life, that's not something that you really want to show or talk about or admit or, to allow to be a defining characteristic. So it just doesn't work at all. So what you do is you're actually compounding the shame, disguising it, compounding it. And shame has a very pernicious quality. It kind of pushes. The feeling of shame, that kind of pushing you forward towards some resolution because it's desperately painful. And so you end up using or drinking or doing whatever you do because there's really it's hard to get rid of shame. It's coming from behind, it's coming from on top, from other people's perspectives or how you imagine other people's perspectives. And so it's really hard to regulate and resolve. It makes the problem worse.
Mm-hmm. And it denies human experience. So it's inherently kind of unattuned, uncompassionate, or maybe based on a compassion for one's suffering, but it's completely not seeing or open to seeing the unique human experience of people.
And also the disease, the notion that mental problems stem from disease processes also infects the rest of the whole psychotherapeutic community, the psychology community. It's depression is a disease and anxiety is a disease. And if you have anxiety, well then, my kids are, my present generation of kids are just graduated from high school. So-and-so has anxiety. Well, they talk about it like it's a disease. So-and-so has depression. Not so-and-so is depressed or having a bit of a hard time. No, they have depression. So again, you are denying human experience. Human experience includes darkness and anxiety and a feeling of needing to resolve things that one can't necessarily see how to resolve for now. That's part of the confusion of being alive. And just shoving that into bins with disease labels is pretty counterproductive. So it's not just addiction.
Now, there's another really problematic and kind of pernicious aspect of it. It locates the problem in the individual in a decontextualized way. So that can really reinforce a denial or negation of the social and relational conditions that may be contributing to why I'm unhappy, right? We live in a world that has so many things going on in it that make it hard for me to sleep at night. If that's my disease, then why should I think about the political insanity, global warming, wars that are going on, the tragedy that is happening in the world, or, the stress that everyone is feeling about it, including me, right? Or, on and on and on. All of the things that we live with in our social relational world.
That sensitive people should be aware of and should be thinking and be bothered and disturbed and depressed by.
That's right. Or my relationship stress, or the if it's my disease that I should go off and fix somehow by committing to abstinence.
So not only is it the whole thing rooted in fear, it's unscientific, it disempowers the person suffering from addiction, it leads to shame and self-loathing, and it considers human beings in this very narrow, isolated biological context, totally separated from their social relationships and the broader environment that they find themselves in. So it's totally ridiculous that it's even an option today. So in addition to that, Mark, one of the things you're most famous for is your learning model of addiction. And that, I think, Andrew has brought into his harm reduction therapy as well. So Mark, could you maybe tell us what the learning model is and its relevance for understanding and treating addiction?
Yeah, well, it started with there's a fundamental truism underlying the disease model that brain change equals brain disease, which of course is ridiculous on the face of it because brains have to change because that's how learning transpires is through synaptic development, synaptic growth, and synaptic pruning. You need certain synaptic networks to shut down so that others can become reinforced and become more streamlined and become more effective. That's what development is. That's what it looks like. When you see areas of the brain changing in adolescence, it's because we are learning to become better thinkers, better operators, more functional in the world. We're developing strategies, and there's a lot of pruning that goes on there. A lot of synapses get shut down because the blooming, buzzing brain that's full of synaptic connections is not the most effective tool to deal with a complex life and an environment that you have to adapt to through experience. Anyway, long story short, I mean, it's like, to me, it's just like a lot of other things. We learn how to solve emotional problems by becoming passive or becoming aggressive or becoming leaders or followers, becoming bullies or victims or helpless or, over dependent. We develop strategies for dealing with emotional pain, and they become consolidated, they become reified through repetition. All learning becomes reified through repetition. That's how learning works. We kind of know that, right? So something that you do a lot of because it's the only thing that really works to make me feel better at the end of a long day in the whatever, at Walmart, is like it's going to keep, if it keeps happening, it's going to continue to reify those channels, those synaptic connections, and it's going to tend to avoid or stop using other synaptic connections, which might be other ways to solve emotional problems. But that's really it in a nutshell. You're learning to solve your problems in a particular way, and it kind of works. And it's better than other things that don't even kind of work. So you keep doing it.
Mm-hmm. So I learned a lot about that from Mark. I talk about it in maybe a less sophisticated way, and with patients, we want to offer them a different model, right? So if we're going to challenge the disease model, how else might you think about and look at and address this problematic behavior or this addictive experience, right? So we've been talking about meaning. If I turn to this substance and it really helps me feel better, it helps me feel more alive, it helps me feel more connected, it helps me feel less like I want to kill myself, I want to keep doing it. But if I keep doing it and doing it and doing it, stimulus, response, reward, I tell my patients, it's like, we train ourselves the way we train our dogs, right? Then when I feel anxious, I want to drink. The urge to drink is what gets reinforced and conditioned in addition to having the drink. So that powerful urge that we've said before is one of the hallmarks of what we call addiction. Over time, reinforced hundreds and thousands of times, becomes deeply ingrained as what we call overlearned habit, or that gets encoded in these neural networks that Mark is talking about. So this is why we can't just be psychoanalysts and help people understand the meaning and even the deep meaning and related to trauma, developmental trauma, and so on. But we also have to be CBT people and teach mindfulness to begin to observe the connections between a feeling, an event, a thought, an urge, an impulse, an action. And I think then we can help people begin to learn basic skills for stopping the action, sitting with the urge, turning down the intensity, being able to think about, options and choices, and then have alternative choices. So this model of meaning and habit is so essential to helping people get the whole picture and be able to intervene in a number of different ways with themselves. There's also biology, which I think maybe we could I'll just say two sentences about, we could talk more about, but aren't there brain changes that happen with chronic substance use? People say, yes. Not only the things that Mark has been talking about, but I think neurochemicals kind of get depleted and receptors change in their sensitivity. But I was thinking about it on the way over here. If we don't eat, we get malnourished. If we don't drink, we get dehydrated. Do we call those diseases? No. And we know that, if people cut back or stop their substance use, a lot of those brain changes with neurochemistry and neuron receptors kind of reset. I mean, is that right, Mark?
And I tend to even de-emphasize that part because it resets so quickly. I mean, even with opioid addiction, your opioid receptors come back to life or become more sensitive again 3 or 4 weeks after you stop. The problem is that real addiction is psychological, and it's not about a physiological need that drives you to use again the next day. It's about coming back the next week or the next month or the next year. It still remains a viable way of dealing with emotional pain, and that becomes deeply embedded and entrenched, and you don't change that. You can't get rid of that. What you can do is start to build pathways around that and say, this is a weakness or this is a pitfall that I am very vulnerable to. So I need to think about this in a different way or connect with people. The fellowship model in AA, uses social connection as a way to not depend so strongly on alcohol or other drugs. So to me, yeah, it's not the toxifying impact of drugs, substances themselves is a pretty minor part of the story for me. It's more of learning itself, which really does um, uh, consolidate synaptic pathways in such a way that there's not as much flexibility left. You need to build new pathways to move around beyond, or, instead of.
And I love your idea of repetition, Mark. That is that these pathways get laid down through repetition. And by that token, if we're going to inhibit, the addictive pathways, and work in a new repertoire of caring for oneself, of coping, of managing distress, whatever, it's through repetition. And don't give up before the miracle happens, they say in AA. Well, the miracle is, new habits get established. So when I feel anxious, I've got this whole other set of responses that over time become more second nature.
And emotional learning is special only in the sense that strong motives are compelling. You need to deal with them right away. I mean, my kid's learning to, play the piano, and that's also motivationally, driven. He wants to do well, he wants to play well, he wants to please people, but it's not as strong a drive as the need to feel that I can walk into a room without feeling like, a complete loser or whatever, or empty, or, lost. So to solve emotional problems, you have to solve them quickly. You have to go to what you know is going to work, what you think has the best chance of working. It's a resolution that is that is, what's the word I want to use? That's pressured. You need to do that quickly, and so the learning tends to develop tight little cycles of emotional stimulation, pain, and then response. And habit building has those tight little cycles, and that's what builds structures more quickly than less motivated learning.
Mm-hmm.
Just to clarify here, are we saying that the same processes are at work for biological or chemical addictions and behavioral addictions? Or is it the same basic thing that's going on within a person's physiology?
Yeah, and that's the other reason why I don't pay a whole lot of attention to the physiological impact of substances themselves. I've dealt with people with porn addictions and gambling addictions and other kinds of interpersonal issues that have nothing to do with substances, but are incredibly resilient and hard to change. So it's not about those changes in particular, about the substance-induced, whatever, so-called toxic changes. I think that's a minor issue.
Yeah. Yeah.
Okay. Well, we're sort of drawing to a close here. So I want to ask you both about your visions for the future of addiction treatment. And you're coming at this both from different angles. Andrew, you've developed a really unique approach, integrative harm reduction psychotherapy. How do you see addiction treatment, best case scenario, let's say 10 years down the line, 20 years down the line, if everything was to go as well as it possibly could?
Well, I'd like to see integrative harm reduction psychotherapy be the standard treatment across the entire field. And I've done a course with Weekend University, so people may go to that course and learn about, my work in more depth or read some of my stuff. But I mean, essentially, I think it's about creating an alliance and a relationship with people as a foundation for doing all of the other work of supporting people and making positive change. And an alliance based on creating safety, keeping our agendas and our expectations out of the picture so that we can support people in discovering their truth and clarity about what goals and approach to change best suit them. And I think that is what a harm reduction framework sort of supports. The basic idea is to reject the abstinence requirement or really imposing any values or agendas on people And that creates this space to support people in their own personal, exploration and discovery. I think then we can, on that foundation, there are a number of other therapeutic tasks that we can help people achieve that relate to the process of changing these complex relationships and developing healthier ones. Just one of them I want to mention briefly, which really relates to Mark's discussion of parts work, is, and this is a kind of an homage to the voice dialogue work, the idea of embracing ambivalence. If there are parts of the self that want to keep using and there are parts of the self that want to change, these parts are often at war and have been, and people are tortured by the conflict and the battle. Hal Stone wrote a book called Embracing Ourselves, which that's my homage. Embracing ambivalence really is about inviting both parts into the therapeutic process and supporting them in having a constructive dialogue about what would be resolutions for the part that wants to use that would be consistent with people's other values, right? And then that leads to kind of harm reduction goal setting. And then we can set about a personalized plan for working toward those goals. But it really emerges out of this kind of harm reduction, listening and alliance stance or relational stance.
The fact that harm reduction meets people where they're at, I think that fits very well with IFS, because if you're not doing that, if you're saying you have to be abstinent first, then you're going to get resistance from those addicted parts. Whereas with your approach, Andrew, it lends very well to working with IFS as well, because you're sort of saying there's a place for all parts here, and let's start by working with you and coming towards us from a compassionate place rather than a place of forcing and discipline and all the rest. So, Mark, what are your thoughts here on the future of addiction treatment?
To be honest, I get stymied by these questions. I think Andrew's approach is terrific. And in a way, I want to leave it to you, because I mean, even the fact that we still call it harm reduction is kind of bizarre. Like, of course, we want to reduce harm, don't we? Can that really be the title of your particular form of treatment? Isn't that kind of obvious? Well, no, apparently it's not. So I get quite frustrated and sometimes pretty concerned about where we're going. On the other hand, understanding that addiction isn't just a problem of particular groups or particular individuals who have destructive leanings and who really don't want to get better and do their best in the world and really want to just tear things down. That kind of prejudice, I think, is peeling back in different ways in different sectors of society. It's probably at its worst in the US, just about, in the Western world. In Europe, the view of addiction is just not as it's not as foul, dirty of an accusation yeah. So, and I think as people realize that a lot of behavior is compulsive, and a lot of people takes time to learn how to be the best person you can be. It's not just a particular subgroup that we need to keep over on the other side of the tracks, and or else in treatment centers or else in jail. That awareness is growing slowly, it seems, but it is growing, and it's even growing in the US, thanks to Andrew, people like you, and other people in the harm reduction and associated movements. So I think it's going slowly. I'm not exactly sure what the right answer is, but tolerance is a pretty big factor. And I'm seeing kids in high school now that are indeed more tolerant than I would have imagined. So my kids who are just graduating from grade 12, they don't see race, they don't see sexual preference. Their friends have all different stripes and colors and affinities. And it's like, wow, society really is changing back there somewhere. There is a kind of sense of acceptance for diversity and for the struggles that people need to go through before they really, really are finished growing up. That, I think, bodes well in the long run.
For sure. For sure. Well, that's a great note to end on. I want to say a huge thank you to you both. You've both been It's been fascinating to speak with you. Where can people learn more about your work online, and maybe if they want to pick up one of your books, which would you recommend? So, what about you, Mark? What's your website again?
So it's called Understanding Addiction. And if you Google Understanding Addiction, Mark Lewis, my website will come up. And I've got a fair number of talks and interviews and podcasts and things of that sort online that are all accessible through my website. There's a whole set of of articles and chapters and books and talks. So that's pretty much it. I even have a Wikipedia page now, so that's cool. And that's it's pretty easy to find me. Andrew, by the way, before we stop, embracing ourselves, was that the author that you were telling me that you were discussing before? That was that Voices Dialogue. I never heard of that.
Yeah, yeah, voice styling. Hal Stone and Sidra Wickelman wrote that.
Okay.
Yeah.
And this stuff has been around for 100 years or so. I mean, we often think about Jung as being one of the four fathers of heart psychology, and so but it's really taking its place in the culture. It's infused in all kinds of ways and places.
It's beautiful. Actually, Hal and Sidra were Jungian analysts, so that was their roots. Uh, so people can find me at andrewtatarsky.com, and I've got a whole lot of stuff there too, papers, videos, podcasts. Um, Also, actually now I'm at freedominstitute.org, and if people go to um, my personal page there, I've got a number of my papers and some interviews with me that people can download. And also, if you go to freedominstitute.org, what you'll see is one of the first kind of array of services that are really trying to offer a harm reduction informed vision of what addiction treatment looks like. We've got an abstinence focused intensive outpatient program, and many people really want abstinence and want intensive structured treatment. And then I think most other people are not there or not there yet, and they want other kinds of treatment. And so we've got a number of different tracks for people, I like to say, in all stages of change and around all positive change goals. And we want to support people in beginning their positive change journey wherever they're ready to begin it as they define it. So
Amazing. Well, I just want to say as well before we wrap up, so these two gentlemen are actually the first two foundational modules on our holistic recovery course. We start with Mark and the learning model, and then we move to Andrew and harm reduction as a foundation for all addiction treatment going forward. So we thought these were probably the most important aspects to get in first. And then from then on, we start looking at addiction in the broadest possible context. We look at IFS, we look at polyvagal theory, we look at social and group interventions, and we also look at existential aspects and meaning making in recovery as well. So we're trying to, create this big context around addiction and see it outside of this biological lens. So we think it's a really remarkable course, and we're making it like as cheap as we possibly can as well. So if you're interested, check that out after the interview. And yeah, thank you so much to you for your time today, guys. And I want to wish you the best going forward.
hey, it's been an honor and a pleasure to dialogue with both of you.
You too, Andrew. And Niall, thank you so much for your leadership and your energy and your activity in this world. You're doing a lot of good. You seem to be unstoppable. I admire it. Appreciate it.
I don't know about that, but
I second that, Niall. Yeah, thank you so much for your important work.
all right. Thanks very much, guys.